the maternal and newborn services. In addition, both the national and county government should work hand in hand to strengthen primary health care system, ensure equitable distribution of skilled health workers, and increase domestic financing for maternal and newborn programs. Development partners, civil society and private sector, on the other hand, can complement government efforts through targeted investments in infrastructure, training, innovation, and health service delivery models. Ladies and gentlemen, in conclusion, the Council of Governors envisions a vibrant and interlinked community of practice where knowledge flows freely, the root causes are interrogated, innovations are scaled, and cross-county linkages are intentionally nurtured. Beyond boundaries and beyond soiled responses, this forum represents a new chapter, a unified, coordinated approach to preventing maternal and perinatal deaths, and further, the initiative brings visibility to cases that fall between counties during referral processes, restoring accountability that transcends administrative lines. Our goal remains simple yet profound. No woman, no newborn should die from preventable causes. Your presence here today reflects a shared commitment to strengthen MPDSR and advancing high-impact solutions that can save lives. The tools and the products we are launching on this day are designed to improve the data use, standardize practice, enhance coordination, and accelerate timely, actionable responses to maternal and perinatal deaths. The Council of Governors remains fully committed to supporting the momentum needed to deliver meaningful change. Let us move forward on a united but a common goal of ensuring that preventable maternal and newborn deaths become abnormal. Asanteni sana. It's now my humble pleasure to invite my colleague, Governor Mandera Khalif, to make a comment, and then in turn invite our whip, who is here representing the chair of the Council of Governors. Karibu sana, Your Excellency Khalif. Governor Mandera, make your remarks and then invite our chair. Karibu sana.
Asante sana, Your Excellency. Ladies and gentlemen, I would like to take this opportunity to thank Council of Governors Secretariat for organizing this program. When I came in and looked at today's program, I think the most catchable word there is preventable maternal and newborn mortalities. So we just need to underline that word. It is preventable. So as a governor who comes from one of the rural, or we call marginalized counties in this country, health is actually the area that I focused on just immediately I was elected to the office. I can say under devolution, we have made a huge progress. Just to give you an insight on the Mandera County, At the onset of devolution, we had 126 health workers across the district then, now what we call Mandera County. 126, serving a county of 26,000 square kilometers. Serving also the neighboring countries of Somalia and Ethiopia, because health has no boundary. But today we talk about 1,600 workforce. From 126 to 1,600. So when some people talk of centralizing health, for those of us who come from northern Kenya or even the country, we just laugh at them, because many people don't know what we have achieved under devolution. We had one medical officer, one, in March 2013. And today, we have over 60 medical officers and over 17 specialists. So even with that number of improvement, we are still talking about preventable maternal and newborn death. Of course, in our cases, it's a bit different, because even referrals, when we are talking about referring a mother, we are talking of 100 kilometers and plus. You know, when we are talking about 26,000 square kilometers. So this program is actually very close to my heart when we talk of this particular one. That's why I traveled from Mandera yesterday to attend this meeting. The chairman, Dr. said, even with the huge investment, the indicators are going down. Then we ask ourselves, why? Simple example. For us in Mandera, a dispensary is a very important facility for us. Dispensary, the border of Ethiopia in Mandera North or in Mandera West is Agagan and Nairobi Hospital of Mandera. Now when you deny deliveries at the dispensaries and health centers, that is level 2 and 3, where actually in the last 2 years we have constructed over 27 new dispensaries, and recently even operationalized 12 more. Then just because of the issues of bed capacity, then we are not progressing. Actually, we are retrogressing. That's why the indicators are going down. So as much as we would like to work with Ministry of Health, I think the issue of SHA should not be politicized. I think that's where the President's intention is very clear. The universal health care is one of the things that we really looked forward to. But how we are managing it need to be looked at it seriously. And the more we sugarcoat it with political statement, is the more these indicators will continue going down. So, SHA, or by extension Ministry of Health, the Council of Governors are willing and ready to support this program, but they should not frustrate our effort. Dr. also mentioned that some counties have started reducing the investment because of the FIF and SHA. Yeah, in some counties, our priority, our demand is huge. So we thought SHA thing will work. What we did this financial year, we invested more in equipping our hospitals, hoping that the money or the resources we'll generate will also support us in issues of farms and non-farms. But when a referral, county referral hospital receive 1.2 million shillings of disbursement, then you can imagine what we are looking at. Having said that, as Council of Governors, we're going to support this program. This program is not competing with Ministry of Health. I think that the chairman said it very clearly. Health is a default function, and there's no citizen for national and county government. We are just serving one community. For us, it is a very important program. I have been thinking about this particular issue of maternal and newborn death. But when I heard of this program, I was really excited, because it does not only tell us how we are faring, but we can even do knowledge transfer from the other counties. So I just want to take this opportunity to confirm that we're going to support this program, and we're going to be the champion. We'll be attending this meeting, and God willing, these indicators will improve. Thank you very much. You know, at the Council of Governors, I'm a very junior man, so I've not been used to inviting the chair. So I just want to take this opportunity to thank His Excellency Governor Duty who is also our whip, to come and make remarks on the behalf of the chair.
Thank you very much, Governor Khalid. Even those who hold positions in the Council of Governors, it's just service. They are just first among the equals, and all governors are equal at the Council of Governors by all means. My colleague governors who have afforded to be here today, with the Speaker Emeritus Governor for Bungoma, Chie Lusaka, Governor for Nandi County, who is also a member of the Health Committee and shares resource mobilization. It's one of the reasons why we're here. And a very committed member of the Health Committee, Governor Khalid of Mandera. Our development partners, who are not mentioned by each by name. Our deputy governors who are here. Each one of you representing your county and your bosses. The caucus of the CECs, headed by the chair, who just spoke very well. The Council of Governors Secretariat, headed by CEO. The MPDSR team, headed by Dr. Mary Maina. Everyone in this room, good morning, and how are you doing? I just wanted to hear that response, because we are meeting in one of those very rare occasions when we discuss issues pertaining to the voiceless in this country. I want to associate myself, before I read the speech for the chair, with the comments that have been made by my colleagues who have just spoken very well at the position of the council. And I want to tell you that this function was so serious that every governor would have been here, and especially the chair of the Council of Governors, Governor Ahmed of Wajir, and also Governor Abdul Samad, the new chair of Health Committee of the Council of Governors, and you're wondering, how can such a serious affair be missed by the governor for the first time? And I want to make it very clear. And I want you to put yourselves in their feet or in their shoes. Before you are a governor, you are a politician. It is the politician that makes the governor or brings the governor here. So today, we are here, the few of us here, courtesy of Section 2A that was repealed in 1991, when we used to be a one-party state. And it was repealed. Now we are very many parties in Kenya. One of the front runners as a party in this country, which is very, very popular and holds most of the leaders, is ODM, which you know very well. ODM is having their celebrations of ODM at 20 in Mombasa, starting from today to Saturday. The governor of Mombasa is the host, and therefore is there making his opening remarks to welcome the others, the rest of the country. The chair of the Health Committee at the National Assembly, Dr. Nyikal, sits in the neck, and I therefore also want to take his apologies, just in case you're thinking that the National Assembly bolted from this. They are with us here. But Dr. Nyikal also sits in the neck. Catherine Muma, who was also supposed to be here, Senator Catherine Muma, is a front runner. She also sits in that governing body for ODM. I don't really have to preempt you that Governor Ahmed, who is our chair of Council of Governors, is one of the leaders in the neck of ODM, and therefore they are there doing what made them governors, and we are here because we belong to the other faction, courtesy of the promulgated constitution, representing them. So that it is clear, you don't think we are bolted. I'm also have a feeling that also the ministry could also be supporting that somehow. That is why they are not here. Eliminating the dispensaries as one of the centers that we can allow our mothers to give birth and be paid by SHA. There must be a reason behind everything. And one of the reasons why, when I engaged the SHA and the CS, is that officially dispensaries are not supposed to be inpatients. And therefore, to curb fraud, they decided the dispensary should not be recognized as a place where a mother came in, gave birth, and left after 3 days. You would imagine that we gave birth and then just sat on the benches for 3 days and left because there's no bed capacity. And surely, and the minister is represented here and recognize you, you can fake any other disease, but I don't see anyone faking pregnancy. Because pregnancy has a product or a visible, which is a baby and happy mother. And therefore we seriously need, as Governor Khalid said, for the ministry and SHA to reconsider that position, because they say that it is in the law, and I believe that law was not made, man was not made for the law. It is the law that was made for man, and therefore they have to change that because it is completely not working, and that is why those healthy indicators are coming down. Then allow me also to say that in African culture, being blessed with a baby, and we always advocate for giving births in facilities where we have experts who will midwife the coming of the baby as compared to traditional births. It is one of those conditions that take you to the hospital and you're not sick. In African culture, it is normally a blessing. Even if you ask them, where is your mother today? Or where is your auntie? Or where is your wife? That she went to the hospital to be blessed, not to be attended to by doctors and be cured of a disease. And therefore it is a blessing. So when the mother goes home mother goes home without a baby, there's no blessing. When the mother does not even go home, and in her own life, she goes home in a coffin and the baby, then that turns the celebration to tragedy. It is like a wedding ceremony that has been turned into a funeral ceremony. That is how serious it is. And therefore, we are here today to assist this very noble cause to be advanced in Kenya. And I want to thank those who started it, headed by Dr. Maina, because like H.E. Khalid put it, mothers have no boundaries. You can do very well in your county, but the mothers from neighboring counties who end up in your hospitals and they did not have any follow-up, or they did not have the assistance to get there, and they're not in your records, and no one has taken the initiative. If your county is doing very well and the neighboring county is not doing very well, we'll definitely end up where we do not want to be, or worse than where we are at the moment. And therefore, it is a noble cause that we are looking forward that it will take place, or rather it will be implemented in all 47 counties of Kenya, so that as a country we can succeed. Allow me now to read the speech of the Chair of the Council of Governors, Governor Ahmed, Governor of Wajir County. It is a great honor to join you today for the launch of the productive families and resilient communities, and they contribute to a stronger national economy. Ladies and gentlemen, for 13 years now, devolution has provided counties with the opportunity to prioritize and invest in maternal health. Counties have made remarkable progress, which is evidenced by the following. Counties have involved, or they have partaken to construct and equip modern maternity and newborn units that are rising in number in Kenya every day. Expanding community health system to ensure early identification and referral of pregnant women. Recruiting and training skilled birth attendants. Strengthening emergency and obstetric and newborn care, integrating MPDSR process into county health plans and accountability frameworks. These efforts have translated into improved access to skilled delivery, enhanced data-driven decision-making, and in some counties, notable reduction in maternal death. For instance, Kiambu Level 5 Hospital reported 0 maternal deaths in a span of 7 months following consistent MPDSR reviews. A testament to what collaboration, accountability, and commitment can achieve. Similar successes have been noted in counties such as Machakos, Kisumu, and Homa Bay. And just to know that successes sometimes which are headed by the politicians faces resistance. You may have noticed a lot of activities around Machakos and Kiambu in those who are trying to somehow camouflage, or they want those particular successes not to be noticeable. However, despite these notable achievements, several challenges still remain in the counties that are grappling with inadequate financing resource constraints, particularly as donor transitions have impacted health, and because we have heavily relied on donors, and we are aware of what political decisions sometimes can do when it comes to pulling out of the donors. Shortages and inadequate distribution of skilled personnel, especially specialists, weak referral systems, and limited emergency transport, socio-cultural barriers that hinder timely access to care, gaps in data and research for decision making, and insufficient psychosocial and mental health support for mothers and health workers affected by adverse outcomes. Ladies and gentlemen, to address these challenges, we must innovate and collaborate. Both levels of government must work together to strengthen private healthcare systems, ensure equitable distribution of skilled health workers, and increase domestic financing for maternal and newborn health. At the same time, development partners, civil society, and the private sector must continue complementing these efforts through investment in infrastructure, training, and technology. The launch of this MPDSR initiative comes at a pivotal moment as the country advances conversation on ending of preventable maternal and newborn deaths through every woman, every newborn, everywhere, abbreviated as EWENA, which I would risk calling EWEN. Acceleration plans of 2025-2027, in which counties have played a central role in shaping development of this plan, ensuring that every investment made translates into real improvements in maternal and newborn outcomes. I think I like this. Every woman, every newborn, everywhere. And I think that it should be a mantra that stick to your head, to our mind when we leave this room today. This MPDSR investment case we are launching today serves as both an advocacy and resource mobilization tool. It outlines priority interventions, implementation of frameworks, and the resource requirements to strengthen surveillance, review responses, and learn at both the national and county levels. The return on these investments that you're trying to invest today, to initiate today, and learning at both the national and county levels. These returns will be measured not only in lives saved, but also in strengthening data and use improve service delivery and enhance public trust in our health systems. Ladies and gentlemen, in our effort to improve maternal and newborn health outcomes, mental health remains an essential and inseparable component. Someone mentioned earlier, a mother who was miscarried or has not gone with a baby, born with a baby, which is part of the blessing, cannot be mentally the same as when they went to that hospital. And therefore we are dealing with a lot of mental cases that is related to this. And that is why the Council of Governors has continued to champion mental health as a very key pillar of maternal well-being. We have supported the training of health workers in mental health and psychosocial support. We have nominated Frontline health workers as a county representative, that is COG's representative, to the Kenya Mental Health Board to ensure counties' voices are represented in national decision making and encourage counties to integrate counseling and psychosocial support services for mothers and families who have experienced tragedy during childbirth, as well as for the healthcare workers involved in such cases. It is important to me to note in this case that one of us who was the champion of starting this, and that is Dr. Mary Maina, who is here. Dr. Maina, you can be upstanding. This is our representative. This is our representative in the board of mental health board in Kenya. Thank you, Dr. Maina. You can have a seat. Moreover, the council, through the inter-county MPDSR platform, continues to coordinate learning and sharing across counties. We have embedded MPDSR information on council's website and will continue hosting a series of engagement to sustain momentum in preventing maternal and newborn deaths. Ladies and gentlemen, this initiative reflects our unwavering commitment to universal health coverage, and by reducing maternal and newborn mortality, we move closer to achieving the goal of quality, accessible and affordable health care for all. The estimated 5,680 maternal deaths and 33,600 newborn deaths annually are more than statistics. These are life lost. Families are devastated and communities are left in grief. Together, we have the responsibility and opportunity to change this narrative. As we launch the MPDSR initiative and investment case today, I call upon all partners, stakeholders, and both levels of government to support its full implementation. Let us strengthen accountability, invest wisely, and work collectively to ensure that every mother and newborn not only survive, but also thrives. Finally, as I conclude, I wish to sincerely thank our frontline health workers in the county health teams and all partners who continue to champion this cause. The Council of Governors remains fully committed to working with all stakeholders to direct resources where they matter most and to ensure that the preventable maternal and newborn deaths become a thing of the past. Let us remain united in purpose, innovative in approach, and compassionate in actions as we build a healthier and more resilient Kenya for generations to come. Thank you, and may God bless you. And as I leave this podium, it allows me to borrow from politicians, because we like it or not, they run the affairs of the world. It is because of our politicians today that we do not have the frontline workers who were in the program that was supported by USAID a few years ago. We like it or not, leave alone in Kenya. In all over the world, it's politicians who run this. And I've never seen such a resilient class of human beings as politicians. You have seen politicians win elections by working with enemies. People you thought that they can never talk to, but they realize this is the medicine to my disease, because my disease is failing to be what I want. And as bitter as it is, I need to talk to these guys so I can be able to win. And therefore they crafted a quote that says that you should never die out of a disease which has a cure that is known, which is affordable, and which is available, unless you're a fool. That is why they will work with enemies to make sure they succeed. And I'm just wondering, the newborn death and the mothers, maternal and perinatal. Is it a disease that is known? Does it have a cure? Is the cure available? Is it affordable? Then why are they dying unless we are fools? We have to make sure that we have to work on it with the resilience of the politicians so that we can be able to save their lives, and it is possible. Thank you very much, and may God bless.
We can do better than that for the governors that have spoken. I think the message is clear and it sits well with us. For the first time, there's a best practice to borrow from the politicians. So I think moving forward, that should be the practice. And I've said for the first time. Now, Your Excellencies, allow me go straight now to the gist of this. We said that we have the 4 agendas, the objectives, and one of it is from the duty bearers, the people that sat together to ensure that we are here today. So we would want to hear the inter-county initiatives, the voices from the frontline health workers that will be presented by Dr. Mary Maina. Karibu sana, Daktari.
Excellency Governors, all protocol observed, ladies and gentlemen, good morning. It's very difficult to speak after Governor Muthomi because he knows I started my medical career in Tharaka Nithi, but that was before devolution, so I left just before devolution came. I feel like our work is done. We dreamt of a day that politicians would talk about maternal and newborn deaths, and not just talk about them, but actually commit to ending them. It's an honor for me to stand here and speak for people who have never had a platform. For a long time, our leaders have had a platform to tell us what we are not doing right, but the frontline health workers have never had that platform. So we created that platform, and that's why we are here today. We are a group of people who are tired of breaking bad news to families that brought their relatives to facilities to get babies and blessings, as Governor said. Today we will leave here, go about our usual business, but there will be a health worker faced with a very difficult role of telling a family that the lady you brought in last night to give birth unfortunately didn't make it, or your baby did not make it out of this labor ward, and that might actually be the only baby that that family ever gets. We sit in National Hospital. We started this initiative in April 2024, and this was out of an experience that we had had spanning a year, where we were able to follow up all patients referred from Kiambu County to Kenyatta National Hospital. We actually didn't know each other. We had never met physically, but I knew he coordinated the MPDSR activities in Kenyatta. So we were able to find out what was the outcome of the mother that was referred from Kiambu County, be it from a private facility, a faith-based, or a public facility. So we sat one day on Kiambu Road, had coffee, and we realized we shared more common problems. That there were 5 highly interconnected counties where patients were crossing county borders, and this is Murang'a, Kiambu, Nairobi, Machakos, and Kajiado. And the 2 referral hospitals in this region, KUTTRH and Kenyatta National Hospital. So for 2 months, we formed a WhatsApp group, and for 2 months, we were just the two of us. We didn't know how to sell this idea to our colleagues, and we were not sure that they would be receptive of the idea. In June, Dr. Chris Barasa was the third person to join. He was then working at AMREF. And the fourth and the fifth person were Dr. Grace Wanjiko from Muranga and Dr. Grace Watau from Bagathi. We then got bold and shared the idea, and a lot of our colleagues from those 5 counties and the 2 referral hospitals joined the team. This morning, ladies and gentlemen, to just show you how much patients cross county borders, I was just informed of a very sick patient, and I can see my Waziri and my CDH are here, who moved from Ruiru sub-county last night and is very sick in Muranga Level 5 hospital, but she's alive. That's feedback we would not have had in the past. This past weekend, I was on call covering maternity in Kiambu Level 5. In those 2 days, we received 4 very sick patients who needed ICU care. 3 of them were from other counties. We thank God they're all alive, but they all came at around the same time, and our head of ICU is here, she can confirm. Dr. Ngu is at the back. This shows you how much patients cross county borders, and sometimes they're actually very sick. And if you don't give the county of origin feedback, they'll keep doing the same thing that they did for that patient to end up being very sick. Any health worker in this country will tell you that one of our biggest nightmares is trying to look for an ICU bed when you have a very sick patient. Maternity complications are very unpredictable. 1 minute a patient is taking porridge in labor, the next minute she has bled out and she needs an ICU bed. It's a nightmare. Sometimes you actually watch patients die. You're stuck with a patient for 4 hours, you can't get an ICU bed, and you lose her. But through this platform, we've been able to have quite a number of success stories. I will not go into details, but I really want to thank Muranga County for being very receptive to patients from as far as Nakuru County. We have taken